You're clearly frustrated. Yeah, I was really hoping today would be the day we would take this breathing tube out. I know, but you know, sometimes it takes several days before a patient's ready to take the breathing tube out. Well, I remember you telling me when you get down to 40% here that he might be ready. Yes, I did. I told you that in the first video of this series. But remember, I said that 40% was just one of the many parameters we look at before we can extubate somebody. Would you mind telling me more of the things you're kind of looking at? Because I feel like I still don't fully understand. Andrew being nice to patients and educating them. Absolutely. So let's talk about some of the things that we monitor while he's asleep. Okay. So the first thing we look at are X-rays. People on that ventilator usually get an X-ray every day, and that way we can track from day to day if their disease process is resolving or if it's getting worse. X-rays that are not improving or that look worse than the day that we put the breathing tube in would indicate that the lungs are just still in the middle of an infectious process and it's not time to take the tube out yet. So how are his X-rays? So today's X-rays showed that he's still got a little bit of fluid on his lungs, but compared to prior days, he is improving. So based on his X-ray today, would you be able to take the tube out? Actually, yes. If that's the only thing we looked at, we would probably be able to take the breathing tube out. Well, that's good. Another thing we look at is the amount of secretions that he's producing in his airway. Ooh, so I feel like he drools a lot. Is that bad? Drooling is actually pretty common, and we do oral care very frequently to make sure that we're clearing all of that out and keeping the mouth clean. So then what kind of secretions are bad? We actually tend to look more at the secretions that are inside the tube. Is there a lot of them? Are they really thick? Are they discolored? Things like that might indicate that there's still some healing that needs to happen. So how do you know when he needs to be suctioned? As a general rule, we do suctioning about every 2 hours with oral care. We can do it more frequently if it looks like or sounds like he needs it. So if he's coughing a lot, if it sounds like he's really phlegmy, sometimes really good respiratory therapists or nurses can just look at this little waveform here on the ventilator and they can tell based on that if he needs to be suctioned. So if you're not here, should I come tell you if I think he needs to be suctioned? I would actually steer you away from that. Suctioning can be traumatic for some people, and so we don't want to do it more than a person needs. It's probably best to let the healthcare workers that are trained to assess him determine when it's time to suction him. So don't come out of the room every 5 minutes and say, he needs to be suctioned, he needs to be suctioned. No, do not do that. Oh. Plus, from a secretion standpoint, he's actually doing quite well. Okay, good. Another thing we look at when he's asleep are his numbers on his ventilator. So like this FiO2 being 40%. Right, so like I said, the FiO2 is the amount of oxygen he's requiring. And when he started, he was on 100%, and now he's down to 40%, which is what we're looking for. We also have a goal for this number here too. It's called the PEEP. We want it to be down to 5. And what is PEEP? So the PEEP is the amount of pressure in the system required to keep the lungs inflated. He started at a PEEP of 10. He's at 5, and that's what we want. Yes, from that standpoint, he's doing pretty well. Is there any other number on here that you're kind of looking at? We're also looking to make sure that he's taking his full breaths, and we look at this number right here, the tidal volume. So what's a good number for that? Well, it's different for everybody because it's based on height, but for him, we've programmed in a number of 450. So if he's not hitting 450 with most of his breaths, that might be an indicator that his lungs are just not ready to take the tube out yet. But wait, so if you program it in, why wouldn't it just give him 450 each time? Wow, that's a really good question. So the ventilator has a fail-safe in it, and it's a pressure setting. So if he's taking a breath and he hits that pressure, it's going to stop the breath. And it stops it because we don't want to overinflate the lung and damage it or pop it. What sort of things cause the pressure to be too high? Coughing, too many secretions, lungs that are still really stiff from infection and they're not stretchy. So I'm watching it and it looks like the breaths are getting to 450 each time. Yeah, when he's asleep, he has no problem getting his tidal volumes, which is a huge improvement from a few days ago. Okay, so his X-rays are better. His secretions are okay, and his numbers look pretty good. Yeah, he's made a lot of strides in the last few days, so he is improving. So then why is he still connected to the ventilator? So even though he's hitting his marks when he's asleep, we also have to look at his numbers when he's awake. Since people don't just sleep all the time, we have to know how they're going to breathe when they're awake up and during the day. He is not happy when you wake him up. No, he's not, and that's really where we're having the issues now, keeping him intubated. Okay, so then what are the things you look at when he's awake? So I think we're going to talk about his awake parameters in the next video. The next video. Yeah, this is video 2, and I'm thinking to get a really good basic education about ventilators, we're going to need about 4 videos. I'm sorry, you keep saying video. Is that a medical term? No, you're just on TikTok. Like the app?